In this video, let us discuss about nephrotic syndrome in pediatrics. So, what is nephrotic syndrome? Nephrotic syndrome is characterized by massive proteinuria, hypoalbuminemia, edema, and hyperlipidemia. So, what is massive proteinuria? Massive proteinuria is protein in the urine that is more than 1 gram per meter square per day. Okay, then what is a normal proteinuria? Normal proteinuria is less than 150 mg per day or equal to 150 mg per day, and in that the albumin will be less than 30 mg per day, so it is excreted only less than 30 mg. And other proteins that are excreted are, you can remember it by mnemonic TABU. What is TABU? TABU means T stands for Tam Horsfall protein, A stands for IgA protein, and B stands for beta 2 microglobulin, and U stands for urokinase. So these are the proteins that are excreted in the urine. So normally the albumin will be less than 30 mg, whereas other proteins are Tam Horsfall proteins, beta 2 microglobulin, IgA protein, and urokinase. Okay, so normally you have to know the ultrastructure of the filtration barrier. So a filtration barrier consists of endothelium, glomerular basement membrane, and food process of the podocytes. So in the Bowman's capsule we have the glomerular membrane, right? So it forms the filtration barrier, and it has three parts: endothelium, glomerular basement membrane, and food process of the podocytes. This endothelium has got fenestrations and it is negatively charged. Okay, and glomerular basement membrane has collagen, laminin proteins, and heparin sulfate proteoglycan. So this is only for basics. So you have to know the basics, right? So we have endothelium that has got fenestrations, glomerular basement membrane that has got collagen, laminin, heparin sulfate, proteoglycan. So these are all negatively charged. And food process of the podocytes. In between the food processes, what is food process of podocytes? It is a visceral epithelium of the Bowman's capsule. So in between the food processes, we have the slit diaphragm, that is filtration slits. So these filtration slits will allow only the 4 nanometers of the substance they'll allow. So these filtration slits will allow 4 nanometers of the substance to pass through. So these are all negatively charged. So what is albumin? Albumin is negatively charged protein. So normally the albumin will get repelled, so it is not excreted in the urine. So normal amount of excretion is only less than 30 mg per day. So this filtration barrier has got size selectivity and charge selectivity. What is charge selectivity? Because it is negatively charged, it only selects the positively charged proteins. And it has size selectivity, that is only 4 nanometers of the protein should pass through. So it has size and charge selectivity. So what is nephrotic syndrome? Nephrotic syndrome is massive proteinuria with hypoalbuminemia, edema, hypovolemia, and hyperlipidemia. So these are all included in the nephrotic syndrome. Massive proteinuria is more than 1 gram per meter square per day. Hypoalbuminemia means albumin is less than 2.5 grams per deciliter. And edema. Why is edema? Edema comes because there is a fall in the oncotic pressure and it causes interstitial edema, and this will cause hyperperfusion to the kidney, that is hypovolemia is there, hyperperfusion to the kidney. So there is a RAS activation, and again there is a sodium and water retention causing edema, and there is hyperlipidemia. Why there is hyperlipidemia? Because liver compensates, because there is hypoalbuminemia, liver compensates by synthesizing the beta lipoproteins. So it causes hypercholesterolemia. So these are the features included in the nephrotic syndrome. What are they? Massive proteinuria, hypoalbuminemia, edema, and hyperlipidemia. Massive proteinuria is more than 1 gram per meter square per day. Hypoalbuminemia is less than 2.5 gram per deciliter. And hyperlipidemia is because of the compensatory synthesis of the beta lipoproteins by the liver. And what are the causes of the nephrotic syndrome? Causes are more than 90% it is primary or idiopathic. And other causes of nephrotic syndrome are amyloidosis, vasculitis, SLE, post-infectious glomerulonephritis, hepatitis B nephropathy. So these are the causes of the nephrotic syndrome. Mostly it is idiopathic, we don't know the cause. So other causes that can be seen are amyloidosis, vasculitis, SLE, post-infectious glomerulonephritis, and hepatitis B nephropathy. So we have two groups based on renal histology. We have two groups in nephrotic syndrome. What are they? They are minimal change nephrotic syndrome and nephrotic syndrome with significant lesions, that are glomerular lesions. So we have two groups, minimal change nephrotic syndrome and nephrotic syndrome with significant lesions. So this minimal change nephrotic syndrome is steroid sensitive, that is it responds to steroid treatment, whereas steroid resistant are glomerular lesions, that are nephrotic syndrome with significant lesions are glomerular lesions, right? So they are steroid resistant. And what is steroid sensitive? So we consider here only the steroid sensitive nephrotic syndrome. It's a most common cause. So 80% will occur in the 2 to 6 years of age group. So 2 to 6 years of age group we have steroid sensitive nephrotic syndrome, that is minimal change nephrotic syndrome. And on renal biopsy, this minimal change nephrotic syndrome, on light microscopy there are no significant abnormalities we could recognize, and when you see in the electron microscopy there would be a non-specific obliteration of the epithelial food processes. Okay, there is an obliteration of the epithelial food processes, and on immunofluorescence you could see the IgM deposits, right? And FSGS is a sclerosis of the segmental glomerular type, that is with the glomerular lesions. And what is the pathogenesis of the minimal change nephrotic syndrome? It's idiopathic. The reason is not known exactly. So there is alteration in the CMI that causes alteration in the permeability, selectivity of the glomerular filtrate, and it causes proteinuria. Normally it should repel the albumin, so there can be any alteration in the selectivity causing proteinuria, and any TH2 proliferation, and any alteration in the T regulatory or TH17 axis. So this is about the pathogenesis. Pathogenesis is not clear. Okay, there is alteration in the CMI, any TH2 polarization, or any alteration in the T regulatory TH17 axis. And next, what are the clinical features of the nephrotic syndrome? So what is a clinical feature? Because of decreased oncotic pressure, the fluid will accumulate in the low resistant areas, that is with loose connective tissue. So where is the loose connective tissue with low resistance areas? It is a phase. So first there is edema, first seen on eyes, and gradually it progresses to the legs regions. And this is a soft and pitting type of edema. Okay, and then it becomes generalized edema, like with ascites, hydrothorax, and hydrocele. Okay, and other clinical features are urinary output may be decreased. Okay, and because of hypoperfusion and hypovolemia, urinary output may be decreased, and here the BP is normal because there is no change in the glomerular filtration rate, and so BP is normal here. If it is increased, you have to think of the glomerular lesions. And blotted appearance, because of edema there is a blotted appearance, and a mother feels that her child is normal because of the bloated appearance. So if at all edema is absent, you can see the muscle wasting. So bloated edema, it will point towards the relative well-being, but it's actually not. And while edema is absent, it is muscle wasting can be seen, and infections can be seen, because all the proteins are lost, all the immunoglobulins are lost, we can get the infection. Children can get the infection. So these are the clinical features. So first there is edema seen on eyes, gradually progressing to legs, and generalized anasarca, hydrothorax, and hydrocele, and urinary output is decreased, BP is normal, and bloated appearance can be seen, and muscle wasting can be seen, and infections can be seen. So these are the clinical features. And what are the laboratory findings? On urinary examination, heavy like 3 to 4 plus proteinuria can be seen. Okay, if PCR is more than 2, PCR is protein creatinine ratio. Okay, protein creatinine ratio normally it is 0.2 mg per mg. If it is 0.2 to 2, it is mild to moderate proteinuria. If it is more than 2, it is heavy proteinuria, that is it indicates +3 +4 on dipstick test. So in nephrotic syndrome we get +3 +4 on dipstick. And gross, if at all gross hematuria is present, you have to think of the glomerular lesion, and hyaline glomerular gas can be present in gross hematuria, or and albumin can be less than 1 gram per deciliter. Hypercholesterolemia will cause milky appearance to the plasma, and blood urea creatinine will be normal in the nephrotic syndrome, minimal change nephrotic disease, except if hypovolemia is present, then it causes renal blood blood flow will decrease, and then abnormal blood urea and creatinine can be seen. Okay, so these are the normal laboratory findings. On urinary examination, there is heavy proteinuria +3+4, and gross hematuria will point towards the, like hyaline glomerular cast will point towards the glomerular disease, and because of hypoalbuminemia will get less than 1 gram per deciliter, and hypercholesterolemia will have milky appearance, and blood urea and creatinine will be normal in minimal change nephrotic syndrome, and blood IgG will be decreased and IgM will be increased. Okay, IgG immunoglobulins will be decreased and IgM will be increased, and C3 levels are normal. Okay, C3 levels are normal, and severity will be indicated by the globulin passage. Okay, so these are the laboratory findings. So IgG will be decreased, IgM will be increased. And what are the investigations you will do? Investigations are, first, urinary analysis. Because of proteinuria, any red cell cast you have to rule out. So urine analysis should be done, and blood tests should be done. Blood levels of urea, creatinine, albumin, cholesterol, albumin, any hypoalbuminemia, hypercholesterolemia, and urinary creatinine and urea ratio. Like if at all any fall in the renal blood flow, will have the urinary creatinine values, abnormal values in the blood. So blood levels, so complete blood picture should be done, and tuberculin test should be done. Okay, so these are the investigations: urinary analysis, blood levels, and tuberculin test. So additional test what you have to do: C3 levels and ASO titers. If hematuria is present, you have to do this C3 and ASO titers, and chest x-ray should be done if tuberculin test is positive, and hepatitis B surface antigen, like any recent onset of jaundice with increased transaminases level, you have to do hepatitis B surface antigen test, and anti-nuclear antibodies like SLA, because these are all secondary causes, and urinary culture if at all any UTIs are present. So these are the investigations that have to be done: urinary analysis, blood levels, and tuberculin test. Additional tests are C3, ASO titers, hepatitis B surface antigen, chest x-ray, anti-nuclear antibodies, and urinary culture. And when you have to do renal biopsy is not usually required to confirm the minimal change nephrotic syndrome, but you have to do the renal biopsy if there are any atypical features are present. What are the atypical features? If age is less than 12 months and hematuria is present and C3 levels are low, and any hypertension is present and patient is not responding to steroids, you have to do the renal biopsy. Okay, because it will all point towards the glomerular lesions. Okay, atypical features, what are the atypical features? They are age less than 12 months, hematuria, hypertension, low C3, and patient not responding to the steroids. Okay, then you have to manage. So you know the definition of the nephrotic syndrome, you know the clinical features, you know what are the investigations that have to be done, and then management. First, initially you have to, for initial episodes, you have to give the high protein diet to the child, and salt restriction should be there, and treat the infections. If at all any infections is present, you have to treat the infection. High protein diet, salt restriction, treat the infection, and screen for the tuberculosis. Okay, then you have to give the diuretics. If at all edema is present, if significant edema is present, you have to give the diuretics. Okay, diuretics, what are the diuretics? Furosemide, what is a dose? 1 to 4 mg per kg in 2 divided doses, or plus or minus you have to give the aldosterone antagonist like spironolactone 2 to 3 mg per kg in 2 divided doses. And if you give the corticosteroids, it will cause, you have to give the corticosteroids if at all any proteinuria is, for proteinuria abolition you have to give, and if you give the corticosteroids, there will be remission within 10 to 14 days. What is remission? It is less than, that is no albumin can be found in the urine, less than 4 mg per meter square per hour. Okay, urinary albumin is nil or trace for 3 consecutive early morning samples. So this is remission. Okay, so you will get remission if you give corticosteroids. And for diuresis and for loss of edema, you have to give the corticosteroids, that is prednisolone 60 mg per meter square per day. Okay, 60 mg per meter square per day, and you have to give it for 6 weeks, and then you have to give the 40 mg per meter square in morning dose, and alternate days you have to give, and this is for 6 weeks. Okay, 6 weeks. Alternate days dose is also for 6 weeks, and then you have to stop. If you give for more than 12 weeks, it will cause corticosteroid toxicity. Okay, So this is about the management. First, initially you have to give the high protein diet. Salt restriction should be done. Treat the infections and give diuretics if any significant edema is present, and screen for the tuberculosis. Okay, diuretics like furosemide and aldosterone antagonists like spironolactone can be given 1 to 4 mg or 2 to 3 mg per kg in 2 divided doses. Corticosteroids should be given for proteinuria abolition, remission, and for diuresis and loss of edema. What you have to give: prednisolone 60 mg per meter square per day, and that is for 6 weeks, followed by 40 mg per meter square on alternate days. If you give for more than 12 weeks, it will cause corticosteroid toxicity. And also you have to do the parent education should be done, and what are the precautions should be taken, like high protein diet, salt restriction, and you have to give the parent education and subsequent course. Like some patient will present with the relapses, like infrequent or frequent relapses. You call it as infrequent relapses if it is 3 or less relapses in a year, and if you'll call it as frequent relapses if it is 4 or more in a year. Okay, and you have to know the definitions of remission, relapse, frequent relapses, and steroid dependence and steroid resistant. Okay, what is remission? Remission is the disease is about to cure. Okay, remission is urinary albumin is nil or trace, that is less than 4 mg per meter square per hour. 4 mg per meter square per hour for 3 consecutive samples. Okay, early morning sample, this is remission. Urinary albumin is nil or trace, that is less than 4 mg per meter square per hour for 3 consecutive early morning samples. What is relapse? It is 3 plus or 4 plus proteinuria, that is PCR is more than 0.2. 3 plus or 4 plus proteinuria or more than 40 mg per meter square per hour in 3 consecutive early morning samples. Okay, and with remission previously. And what is frequent relapse? It is 2 or more episodes in 6 months, 4 or more episodes in 12 months. So this is about frequent relapses: 2 or more in 6 months, 4 or more in 12 months. What is steroid dependence? Steroid dependence is 2 consecutive relapses on alternate day steroid therapy or with 14 days of discontinuation of the steroids. So this is about steroid dependence, that is 2 consecutive relapses on alternate days of steroids or within 14 days of discontinuation of the steroids. And what is steroid resistance? It is there is absence of remission even if you are giving the steroids, it is not responding. Okay, absence of remission despite therapy with prednisolone 60 mg per meter square per day for 4 weeks or alternate days dose for 4 weeks. So these are the definitions. So what is remission? It is urinary albumin is nil or trace, that is less than 4 mg per meter square per hour for 3 consecutive early morning samples. Relapse is 3 plus 4 plus proteinuria or more than 40 mg per meter square per hour for 3 consecutive early morning samples. Frequent relapse is 2 or more episodes in 6 months, 4 or more episodes in 12 months. Steroid dependence is 2 consecutive relapses on alternate day prednisolone therapy or alternate day steroids or within 14 days of discontinuation of the steroids. Steroid resistant is absence of remission despite the therapy with prednisolone for 4 weeks or alternate days steroids with 4 weeks. So this is about the steroid resistance. Okay, then management. How you will manage these relapses, steroid resistance, steroid dependence? So how you will manage? For management of relapse, normally the relapse is triggered by the infections, so you have to give the symptomatic therapy. If 1 plus 2 plus low grade proteinuria is there, you have to give the symptomatic therapy. For 3 plus 4 plus proteinuria with relapse, you have to treat like prednisolone should be given 60 mg per meter square per day until the protein is negative for 3 consecutive days. Okay, for 3 consecutive days protein should be negative or trace should be there, and then you have to give on alternate days 40 mg per meter square per day prednisolone for 4 weeks you have to give. So normal total treatment duration is 5 to 6 weeks. So for the relapse or 3 plus 4 plus proteinuria, treatment is prednisolone. Okay, 60 mg per meter square per day till 3 consecutive samples are negative, and then you have to continue with the alternate dose 40 mg per meter square for 4 weeks. So total duration will come around 5 to 6 weeks. Okay, and for first 2 to 3 relapses you have to treat like above treatment for 5 to 6 weeks, or if at all the pattern is known, you have to individualize the treatment. Okay, then how you will treat the steroid dependent? So what is actually steroid dependent? Even on like if you are stopping the steroids or if you are giving on alternate days, the disease again there is a relapse, so you have to continue with the steroids. But steroids continuation can cause steroid toxicity, so you have to give the low dose steroids. So you have to give a long term alternate day prednisolone. So for steroid dependency, long term alternate day prednisolone therapy should be given. So first you have to treat the relapse like before, and then you have to give the dose of prednisolone should be tapered on alternate days, and you have to give it for 9 to 18 months. So this is long term alternate day prednisolone, and it will maintain the remissions. If at all infections are present, you have to give the small doses, because relapses are normally triggered by the infections. You can start at the onset of infections, like for 5 to 7 days you can give the small doses. Okay, if repeated relapses are present despite on long term prednisolone therapy, you have to consider the steroid sparing agents. These steroid sparing agents are, they're nothing but low dose steroids, they'll spare the steroids. Okay, so for steroid dependency, you have to give the long term alternate day prednisolone. First you have to treat the relapse, then the dose of prednisolone should be tapered, and you have to give it on the alternate days for 9 to 18 months, and it will maintain the remission. If infections are present, you have to give at the start of onset of infections for 5 to 7 days small doses. If repeated relapses despite the long term prednisolone therapy, you have to consider the steroid sparing agents. So what are the steroid sparing agents? Steroid sparing agents are, so before knowing that, you have to know the indications. Indications are prednisolone threshold is more than 0.5 to 0.7 mg per kg on alternate days, and features of corticosteroid toxicity, you have to switch on to the steroid sparing agents. So what are the indications? Prednisolone threshold is more than 0.5 to 0.7 mg per kg, and features of corticosteroid toxicity. So what is the order of giving the steroid sparing agents? It is levamisole. You have to know the dose, you can see it in textbook. Okay, levamisole, it is a immunomodulator, and cyclophosphamide, mycophenolate mofetil, and cyclosporin tacrolimus can be given. So these are the steroid sparing agents, and other is rituximab. So what are the steroid sparing agents? They are levamisole, cyclophosphamide, mycophenolate mofetil, and cyclosporin tacrolimus, and rituximab. So these are the steroid sparing agents. And what is the complication of the nephrotic syndrome? It could be edema, infections, thrombotic complications, hypovolemia, acute renal failure, and other is steroid toxicity. So for edema, you have to restrict the salt, and oral hydrochlorothiazide can be taken, diuretics and furosemide or spironolactone can be taken, and albumin infusion can be given. So this is a treatment for the edema: salt restriction, oral hydrochlorothiazide, furosemide, spironolactone, and albumin infusion. And infections, most commonly the infections are with the streptococcus pneumonia and varicella. So pneumococcal vaccine should be given, and for varicella treatment, oral acyclovir can be given for 7 days, or if it is severe, IV acyclovir can be given. And varicella vaccines are also acceptable. Within 4 weeks of infections of steroids you have to give. And other infections that are possible are peritonitis, cellulitis, pneumonia, and meningitis. So infections. And thrombotic complications are renal, pulmonary, and cerebral complications. So you have to give the low molecular weight heparin followed by the oral anticoagulants. Okay, and hypovolemia, acute renal failure can be there, and you have to discontinue the diuretics, and you have to give the normal saline. If it fails, you have to give the 5% or 20% albumin. Okay, this is a treatment of hypovolemia and acute renal failure. And steroid toxicity. What are the features of steroid toxicity? Cushingoid features: short stature, hypertension, osteoporosis, and subcapsular cataract. Okay, short stature, hypertension, osteoporosis, and subcapsular cataract. So what is a treatment for the steroid toxicity? You have to use a steroid sparing agents like levamisole, cyclophosphamide, alkylating agents, and cyclosporin can be given. Okay, these are the complications of the nephrotic syndrome: edema, infections, thrombotic complications, hypovolemia, acute renal failure, and steroid toxicity. So now coming to the steroid resistant nephrotic syndrome. Steroid resistant nephrotic syndrome, it will first you have to exclude the systemic infections. Okay, exclude the systemic infections, and baseline assessment like renal function should be done, albumin blood level should be checked, cholesterol proteinuria should be checked, and investigations for the secondary causes should be done. And then after doing all this, after you exclude all these causes, you have to do the renal biopsy before the treatment. So renal biopsy should mainly indicated in focal segmental glomerulosclerosis and chronic tubulointerstitial diseases. Okay, you have to test for the hepatitis B surface antigen, anti-HCV, IgG, and HIV. And familial sporadic can also be there in steroid-resistant nephrotic syndrome, like homozygous or compound heterozygous mutations can be there. Mutations can be seen in the podocin or nephrin gene, NPHS2, NPHS1, or Wilms tumor WT1 gene. More than 70 genes can be seen in steroid-resistant nephrotic syndrome. So gene sequencing should be done, and mutational analysis should be done if at all there is a congenital nephrotic syndrome, family history of steroid resistant nephrotic syndrome, sporadic interstitial steroid resistant not responding to the calcineurin inhibitors, and girls with a steroid resistant focal segmental glomerulosclerosis. In them, mutational analysis should be done. Okay, management. So renal outcome predictor is a proteinuria. It is not the renal histology. Okay, aim is to induce or maintain remission and avoid the side effects. Partial remission is also a satisfactory treatment here, and you have to give the immunosuppressive agents like prednisolone and ACE, angiotensin convertase enzyme inhibitors should be given. And best results are with calcineurin inhibitors like cyclosporin, tacrolimus, cyclophosphamide, and high dose corticosteroids with cyclophosphamide. Okay, so this is a management of the steroid resistant nephrotic syndrome. Mainly you have to consider the mutational and gene sequencing because they are mainly sporadic. Podocin genes can be included. And adjunctive therapy, you can give the AC inhibitors, enalapril, ramipril, ARBs, losartan, valsartan, HMG-CoA reductase inhibitors for hypercholesterolemia, control the hypertension, edema you can control with diuretics, and you have to give the albumin. Albumins for symptomatic hypovolemia if symptomatic edema and marked ascites is present. If marked ascites and symptomatic edema is present, you have to give the 0.75 to 1 gram per kg albumin, or 20% albumin should be given for 2 hours, then followed by the furosemide 1 mg per kg. If symptomatic hypovolemia is present, you have to give 10 to 20 ml per kg of albumin, or 4 to 5% of albumin. Close monitoring should be done to avoid the pulmonary edema. Okay, so this is the adjuvant therapy for the steroid resistant nephrotic syndrome. ACE, ARB inhibitors, HMG-CoA reductase inhibitors control the hypertension and edema. Give the IV albumin. If edema ascites is present, it is 20% albumin. If hypovolemia is present, it is 4 to 5% albumin. And what is congenital nephrotic syndrome? Its presence within first 3 months of the life with anasarca, hypoalbuminemia, and oliguria. Okay, etiology is heterogeneous etiology, Finnish form like autosomal recessive mutations in NPHS1, nephrin genes, and podocin genes can be there. On renal histology, you can see the microcystic dilatation of the proximal tubules, and ultrastructural abnormalities of the glomerular basement membranes can be seen at the birth with increased alpha fetoproteins, that is in maternal serum and amniotic fluid you can see. So in antenatal screening you can screen for this nephrotic syndrome, congenital nephrotic syndrome. Raised alpha fetoprotein levels, microcystic dilatation of the proximal tubules, and ultrastructural abnormalities of the glomerular basement membrane. And the clinical course will be failure to thrive will be present, and recurrent infections will be there, and hypothyroidism can be there because of thyroid binding globulin is excreted in the urine, will get the hypothyroidism. And renal failure for 2 to 3 years can be there, it can present. So failure to thrive, recurrent infections, hypothyroidism, and renal failure. And what is Dennis-Dice syndrome? It is associated with the Wilms tumor gene mutations, and congenital nephrotic syndrome with male pseudohermaphroditis, and bilateral Wilms tumor can be there. And diffuse mesangial sclerosis, on renal histology it will present. Other causes will be infections and mutations can be there. And what is the treatment of the congenital nephrotic syndrome? You have to give proper nutrition because there is failure to thrive. There should be a proper nutrition, edema control, and thyroxine supplements, ACE inhibitors or indomethacin, IV albumin infusions every 2 to 3 weeks, and it will reduce the hypovolemia and albumin, and it will avoid the hospitalization if you give the albumin. So nutrition, edema control, thyroxine supplements, ACE inhibitors, indomethacin, and IV albumin infusions. So this is about the nephrotic syndrome. Thank you guys.